Hello everyone, my name is Sherlyn and I'm a student nurse and paramedic based here in Melbourne, Australia. This is my video journal where I reflect on things I've learned in my degree and try to bridge any knowledge gaps that come up. So this semester we're studying common paediatric emergencies and a lot of questions came up around the respiratory stuff. So just a quick disclaimer before we go any further. This presentation represents my own research and is not peer-reviewed. I don't speak on behalf of my uni or any other organisation, and I'm definitely not a paediatrician. So please, if anything sounds off, then I highly encourage you to seek another opinion or just do some further research yourself. Alrighty, so why have I made this video? Well, this week at uni, there was a statement in my syllabus that read, "A child has a rib cage that does not expand easily for breathing." But what does that mean exactly? And I don't know about anyone else, but I definitely didn't cover any specific pediatric A&P in my first year. So this statement left me more perplexed than anything. And I felt like it was really necessary to understand this better, seeing as we know that respiratory emergencies are one of the more common problems we see in children as paramedics. And we know that respiratory failure is a major cause of arrest in peds. So if you're like me, you're someone who needs the biology to support your clinical thinking. So this brief video will aim to increase understanding on the mechanics of pediatric ventilation. I'm mainly going to focus on muscle movement, not really going to go into cell level stuff, but hey, if you like this video, just shoot me a message and maybe I can look at making a sequel. Okay, so let's have a look at an infant rib cage versus an adult rib cage. Right away, you can see that it's very anatomically different. And of course, these differences become less pronounced as the child matures in age. However, for learning purposes, I'm using the diagram of an infant rib cage in this video because I feel like it just illustrates my point a lot more clearly. So please understand that the rib cage doesn't look like that all the way throughout childhood. So when we talk about the main anatomical differences, two things really stand out. Firstly, you'll see that the diaphragm in a child is flatter and less dome-shaped than that of an adult. So, the second important point to note is that in a pediatric patient, the insertion of the ribs actually sit a lot more horizontally. And these two things really make a big difference to the child's inspiratory capacity. To understand that, let's quickly review the mechanisms of ventilation. So when an adult patient breathes in, this dome-shaped diaphragm flattens out, and this drags the lung downwards. At the same time, the intercostal muscles contract, lifting the ribs up and across, and this causes the lungs to expand out horizontally. And this, of course, increases the lung volume, creating a negative pressure gradient that moves air into the lungs. So in an adult patient, those ribs are angled downwards, so there's a lot of room for the ribs to expand out horizontally during inspiration. Unfortunately for the child, well, they're at a mechanical disadvantage because those structures are already sort of raised, and so the act of inspiration results in a relatively small increase in lung volume. The next important point to note is that pediatric patients have relatively large internal organs compared to the size of their thorax. So those organs are really squished in there quite tight. This is definitely not anatomically correct. Whereas I guess in an adult patient, the organs sitting a lot more loosely. These are exaggerated diagrams. So unlike an adult, those lungs and organs are really squished in there. And this tight space really limits the lung from being able to expand too much during inspiration. Our final point to remember is around lung compliance. Now remember, compliance is the ability of hollow organs to expand and distend. Compliance equals distendability. So in pediatrics, chest wall compliance is higher because those ribs are very cartilaginous, meaning they're not made of rigid bone. But despite this, lung compliance is actually decreased due to the relative deficiency of surfactant. Now remember what surfactant does. Surfactant decreases the surface tension of water on the surface of the alveoli. So if you don't have much surfactant, you've got high surface tension. And this, of course, makes it super hard for those lungs to expand. So basically, if you've got a situation where the chest wall compliance is increased, but the lung compliance is decreased, you've got a situation where the alveoli are very prone to collapsing inwards when the chest recoils back to its normal size during expiration. Okay, so what's the significance of all this? Well, first I want to remind you of a concept called minute volume, which is essentially how much air you breathe in a minute. So of course the formula for minute volume would be respiratory rate times tidal volume. And hopefully this video has made it really clear that the anatomical differences in childhood places the pediatric patient at a mechanical disadvantage for ventilation. The act of inspiration results in a relatively small increase in lung volume, ergo, a relatively small increase in tidal volume. So for children, a change in respiratory rate is a cardinal sign of respiratory distress, because they have a limited ability to actually increase their tidal volume. And they always teach you all the way throughout your degree that resp rate is the first vital sign. And I guess you can consider that even more pertinent in a pediatric patient. Alrighty, thank you so much for listening. I hope this video was useful to someone out there. Like I said before, I'm not an expert and I'm totally happy for any constructive feedback. My email is listed there for any correspondence. Here are some references.